Hey guys, welcome to this lesson on pediatric medication administration. We're going to talk about a number of different components and also show you some hands-on examples of ways of administering medication to a pediatric patient. A couple things that you're going to need throughout this lesson. One includes your MyMedic cards. This is the Michigan Medication Emergency Dosing and Intervention cards created through the MyPeer study and then through the EMSC for Emergency Medical Services for Children here in the state of Michigan. Let's go ahead and get started. When we think about vascular access, we have to ask ourselves a lot of different questions about where the child is in their development and growth. A newborn, it's going to be more likely for us to access the venous system through an umbilical catheter. It may also be possible for us to access it through an interosseous infusion or a peripheral IV. We oftentimes have to make sure that we ask ourselves, where is the best location given the current circumstances and resources I have available? We're going to kind of go through the gamut of all the different components you can use, but we don't always have to start IVs. That's one thing in pediatrics that we have to recognize, is that sometimes IV lines are important, but oftentimes they may be unnecessary given a regular routine pediatric call. For those more advanced or more critical calls, we may be using more advanced procedures than we're regularly used to, hence the reason why training is so important. So remember, just because we have to or just because we can doesn't mean we should. We also know that the locations for IV sites are going to be similar to that as to adults with some minor changes. We know that oftentimes in pediatric patients their vessels are going to be harder to find because they're smaller. Oftentimes we know one of the number one causes of an EMS call for paramedics is dehydration of a pediatric patient, which makes it harder for vascular access to be obtained. Or they're very small. Maybe it's a newborn where vessels are so small or potentially non-visible. We may have to consider things like umbilical catheterization or interosseous access. Now there are a number of different locations we can utilize to gain peripheral IV access. These include things like the scalp. Typically in those cases you would use a butterfly needle. This is actually an actual needle. I've got a safety cap right now. But the needle actually remains in the vessel, unlike an angiocath or a regular IV catheter. In this case, you can see the wings on this, which refers to it as a butterfly, give you the ability to kind of hold and maneuver the needle nicely. It's not very long, makes it easy to get into those really small vessels. It comes in much smaller sizes, and then easily can be taped down and secured in place, and then connected to your primary IV tubing. Again, scalp veins are a prime location, especially in those that are young, newborn, or infant. As they begin to grow and develop, arms, legs, and feet always become a optimal site for peripheral IV access. Just remember, again, if your patient is critically unstable, we're going to want to try to get them IV access as quick as we can, and sometimes in kids it can be rather difficult. We may want to consider moving on to an more advanced procedure of an interosseous infusion. We are able to consider the neck for jugular vein access if necessary, but remember, kids don't have good necks. They're very short. Their head just kind of sits on their shoulders, and it's a risky procedure because the vessels are smaller and everything is closer together, and it puts you at a greater risk of causing more problems to your patient. Oftentimes, IO is the way to go. We also know that we need to use the right tool for the right job the first time, and that means selecting the proper IV catheter or IV size. We typically think of these based on adults, right? We say, well, an adult, we normally would shoot for 20 or an 18, which is good for infusions or some fluid replacement, maybe even for trauma and things like even a blood transfusion for 20 gauges on up. We know that for pediatric patients, the likelihood of us using a 18, 16, or 14 gauge IV angiocath is pretty rare, if not impossible. We're generally going to use things like our 22s, 24, or even 26 gauge needles. Those may be indwelling angiocaths, or they may be in the form of a butterfly needle. Now, if you look at the chart here, for size 22 gauge needles, you can see it's good for most infusions, but it's also good for neonates and pediatrics. It can also be used to administer blood. As we get smaller with our 24 gauge catheters, or our yellow catheters in this case, we can see again for most infusions, it's also good for neonates and pediatrics, and again, it still can be used for blood transfusions in neonates and pediatric patients. And then as we get down even farther, which is very hard to find catheter size-wise, which is a 26, you can easily see that those are primarily used only for pediatrics or neonates, but it's a very, very small catheter. It's very limited in what it can do for your patient. We also know that interosseous access is also a relatively common practice now in the field for both adults and pediatrics. And we know that IOs, believe it or not, are more common in pediatrics than adults, but we run a lot more adult calls than we do pediatrics. So we get familiar with the adult process, but not as much for the pediatric. The idea behind this is that the proper placement is key. The wrong placement could easily affect the growth of the extremity, or even worse, the ability for you to get life-saving medications or fluid into your patient in their time of need. We also have to make sure that we select the right tool for the job. As you can see by the image, we have access points which allow for us to determine if we're using the right type of IO needle, in this case with the Easy IO, and then to make sure that it's properly fitting and that it's not going to be too shallow of a needle itself where it won't actually enter into the canal and be able to access the bone model and the circulatory system. Now, indications for IO, there is a ton of them. As we look at these, primarily we see things with shock or cardiac arrest, an unresponsive child or infant, sepsis, or multiple unsuccessful IV attempts, and then trauma as well. All of these are indicated for IO type access. There are some contraindications that we need to refresh again. These include fracture to the extremity or fracture to the pelvis that's proximal to the IO site. Again, multiple fractures in a leg or fractured pelvis, all those are going to limit the ability for the IO to infuse back into the central circulatory system. There's a number of different types of tools that you may see used in the field. The most common one that is used now is the Easy IO. There is a number of different types of IO guns. This is a battery operated like drill. They also have now the SAM IO, which is a hand-driven drill-like device, almost like a ratcheting type device, kind of neat. And then we have older styles or more traditional styles, which include the Jamshetti, or in this case, as denoted in the image, the Jamshetti. Last but not least is your big IO gun device. These are not as common practice as what they once were, solely because of the fact that as they do work, they don't work very effectively regularly. Most of the time when we see these, when we use them for adults, it can actually fracture the bone and cause a lot more problems because of the force of insertion of that needle. And again, these are recommended for adults only, not for pediatrics. When we think about Easy IO, since it's the most common, we have to talk about sizing. Again, remember that saying, the right tool for the right job the first time. There are 3 sizes to accommodate interosseous access in patients 3 kilograms and larger. So we know that we can get from really teeny tiny all the way up to much larger as we go. The 15 millimeter needle set, which is the one that's denoted here at the top of the image, which is the pink one, it's designed for use in pediatric patients that are weighing anywhere between 3 to 39 kilograms and for the patient with minimal tissue over the insertion site. Remember, as we take a look here, you can kind of see in my mouse, this little tick mark here, right? Those are going to allow for you to determine that you can actually, that you see, let me grab my laser pointer here to make it a little easier. Here we go. We can see that mark once we place the needle in. So you'll place the needle in, you'll find your location, you'll press it to the tissue, and set the needle against the bone. If you can't see that little black tick mark, then you know it's not the proper sized needle. We have to be able to see that one. Same thing you can see here on the standard adult, and then same thing here on the large adult. Now you can use these in smaller age groups. We just wouldn't sync the IO flush to the hub. For your 25 millimeter needle, which is your blue guy right here, it's designed for any patient that's weighing more than 39 kilograms or for a patient who has too much tissue over the insertion site for a 15 millimeter needle. Lastly, we have our large adult, which is our 45 millimeter needle set. This is designed for patients weighing more than 39 kilograms who have excessive amounts of tissue over the targeted insertion site, either because of edema, maybe large muscles, or obesity. We also know that the 45 millimeter needle set is ideal for a humerus site, especially for patients over the 39 kilograms. Jamshetti sizes, there's 2 primary, 15 gauge and a 18 gauge. 15 gauge is going to be 1 7/8 inches in length, and the 18 gauge will be 1.5 inches in length. I also wanted to give you a couple different versions of this. You can see here's an example of that Jamshetti. This is an example of an Illinois. This is another example of what they're referring to as a Jamshetti disposable. aspiration needle, which is the same one that we have here in our kit. And then we also have the Cook IO needle and a Surfast needle as well too, which these are probably not as common for us to utilize in the pre-hospital setting. Again, these are good to know because they are our backup devices when the EZ-IO fails. For the big gun, we've got to recognize that there's a certain color that goes with it. In this case, we're going to see red will be for your pediatric patient, blue will be for your adult. Going to follow the same type of procedures you would normally do. Find your landmarks. You would remove the safety needle component here that you can see. This is the safety pin that you would use, and you pull that, and then you would allow for the needle to come out here down through the bottom. Okay, removing this needle allows for me to go ahead and take it and press this down, and it will release the needle. Again, it does come in pediatric and adults. The pediatric are 18 gauge, the blue, which are adult, are 15 gauge. Again, not a lot of success with these that I've seen solely because of the fact that it's so much force as it ejects out, it can actually fracture the extremity. We also know that when we're dealing with pediatric medication administrations, everything is based on weight, especially when we're using your MyMedic card. We don't want to guess, we want to know, right? We want to make sure we actually know their weight. So the best way to do that is to use some type of measurement weight tape tool. This includes a Brasilo tape, or it may include something along the lines of a MyMedic tape as well. You have the tools, make sure that you use them. If you want to double check their weight based on your Brasilo tape or your MyMedic tape, ask the parents. They're a great historian when it comes to the child's most recent weight. Again, they track these things when they go to their doctor's appointments, and it's very common for a parent to have relatively recent data in front of them or that they can pull from memory in regards to the child's weight. It's always important to be accurate when it comes to medication administration in peds. Again, we talked about making sure you use the proper tape-based Brasilo tape or the MyMedic tape, or again using the age-based weights on the MyMedic cards. This is not a fail-proof system. Sometimes children come in very large weights, but in a small package. So they may be smaller, but weigh more. So again, height is not always the best way to do that. It's always good to confer with your parents, but when in doubt, use your reference guides. That's your best bet. Obviously, we're going to measure the child. If we're using the Brasilo tape, one of the things you'll notice here is that the red strip gets put to their head. Remember, red at head, measure to the feet. So red at the head, measure to the feet. You determine what color that they would fall in with your MyMedic tape or your Brasilo tape, and then we would flip to the correlating color. In this case, we can see that this child is measuring into the yellow zone, and so we can assume that this child would be anywhere between 19 to 35 months, and that they would weigh anywhere between 12 to 14 kilograms or 26 to 31 pounds. Again, in the MyMedic card, it's going to have information available for you. It's going to include things such as their cardiac resuscitation card, and then also there's your conditions and your medication card. Makes it for a nice, easy resource for you to utilize after you've measured the child, because based on the common concentrations and common dosing, we can begin to quickly and safely administer medications to a pediatric patient. Now, just like with medications, fluid therapy is just as critical. We need to be accurate when it comes to administering fluid. Too much fluid can lead to heart failure and pulmonary edema, fluid overload, and obviously too little fluid can be ineffective. So we've got to shoot for that sweet spot. Again, this is going to be based on our IV access points, either IO, umbilical, or peripheral venous access. When we talk about treating shock in the pediatric patient, one of the big things that we have to recognize is the proper dose. For a general pediatric patient, not a neonate, we would see the dosing be 20 mLs per kilogram. That'll give us the maximum amount of fluid bolus that we can give, and we can repeat that one additional time if necessary, or up to 2 times per protocol. We know for neonates, again, we're talking from less than 1 month, we can oftentimes use 10 milliliters per kilogram and double that as well if necessary for fluid replacement. If we're going to be dealing with septic shock in our pediatric patient, again, not the neonates, but just the pediatric patients, we may need to give up to 60 to 80 milliliters per kilogram. Again, not all at once, but over a period of time. And remember, we're primarily using our 0.9% sodium chloride or lactated ringers, as those are both our isotonic crystalloid solutions, which will prevent the movement of any fluid from the vascular system or from the cells. Remember that with pediatrics, Medications, the first thing we're going to deal with is respiratory related. If you remember your inverted pyramid for pediatric resuscitation, you know that medications is one of the last things that we're actually going to do. But when we get down to that point of the pyramid, we know that it's very important that we're accurate with what we're doing. So most of the medications you're going to administer to pediatrics will be focused on around respiratory. From there, cardiac arrest and shock are also normally going to be part of that component as well, but generally it's related to an early onset of respiratory related issues. So if we can treat our patient aggressively to begin with, using the proper medications and the proper dosing, we may be able to hold off that arrest or shock. If not, we're going to use those medications as appropriate as well. When are meds needed? Well, we know that we're going to use our MyMedic cards to help us determine what meds are needed based on our standing protocols or operating procedures. It's very important that we check to make sure that we're correct. Just as important as it is to perform a medication cross-check procedure, it's just as important to make sure that we've verified the proper medication prior to administering it to our patient, especially when we're dealing with small volumes of medication. The MyMedic cards make administering drugs much easier than it has been in the past. We measure every patient just in case, and then we would grab the cards and we would be able to identify the medication in the proper dose. Remember, when in doubt, look up things before you make patient contact. Spend some time in the cab of the truck on the way to the call reviewing these to make sure you know what you're looking at. Remember, just like anything, if you don't use it, you'll lose that information. And we don't use pediatrics, or we don't run pediatric calls very often, so it's very important that we have a good, strong working knowledge of how to reference and utilize our MyMedic cards to prevent error. Now, one of the things that oftentimes will get confusion is ibuprofen versus Tylenol in the pediatric patient. Based on the pediatric fever protocol, we know that we can administer either ibuprofen or Tylenol to our patients. For ibuprofen, we know that we want to make sure the child's at least 6 months or older. It's only given every 6 hours, and it's primarily used for reduction in inflammation. Even though it does have some components of inflammation reduction in adults, for pediatrics, it's mostly used for fever. And a lot of times it can be used in conjunction with acetaminophen or children's Tylenol. Mostly your common dosing you would see would be 100 milligrams and 5 milliliters, or something very similar to that concentration. When we're dealing with acetaminophen, we're doing a little bit different. Normally it's 160 milligrams and 5 milliliters. It's given every 4 hours, and it's great at reducing fevers. One of the big concerns that we have to worry about, though, is the excessive use, which can lead to liver toxicity. Both medications, ibuprofen and Tylenol, can lead to toxicity if not properly regulated with the child. If you're dealing with a pediatric patient and you know that they've been responsive to ibuprofen or Tylenol and it's been used regularly in the past, it's not a bad idea to stick with that medication. If we know that it hasn't worked, the mother or the caregiver has been giving Tylenol, it's not been effective, we can try switching things up and using ibuprofen as an alternative, as long as it's not been, the previous medication has not been administered too closely together. We still need to make sure that we mark our times out properly when it comes to dosing, so that we're not overdosing or double dosing our pediatric patients based on what the patient or caregiver has been administered. We also know that when it comes up to drawing meds, that we're going to use a stopcock. It's very, very hard to measure out 1.6 milliliters on a 10 ml syringe. It's almost impossible to do that. Even the same thing on a 5 milliliter syringe. So when we're using these tools, we have to make sure that we're using them properly. That's where the stopcock method will come into play. We'll have a chance to kind of play around with this here in a little bit. The last thing that I want to kind of leave you guys here with is the medication cross-check. It's very important for this to take place every time we're going to be giving any medication. It allows for us to check our 5 or 6 rights for medication administration each time that we give a new med to our patient. Again, we've got our nice dosing charts that we can utilize to reference, but we still need eyes from another provider to determine, do I actually have 5 milliliters drawn up, or do I have a little bit more than I need? Let's run through the medication cross-check procedure real quick. The first provider will go ahead and initiate the cross-check procedure by saying med check. The provider 2 will identify that they are ready to perform the med check by saying ready. From there, the provider will say that I'm going to give X number medication. This is the dose, the drug name, the route, the rate, and the reason why, right? From there, I'm going to confer with my partner and say, do you feel there's any contraindications? The provider too will identify if there's any contraindications, or they'll identify to the negative. If there's no contraindications, then I would state no contraindications. There would then be a concern or a consult to determine the proper volume, quantity, if we're going to be giving things orally. In this case, they would say volume. They would confirm that we're giving half a milliliter. They would take a look at it, and they would look at it again. They would state the drug concentration, state the volume that was to be administered, and then show this to the second person. The second person would look at this. They would confirm that it says 0.5 milliliters, and they would give ahead in the positive to say go ahead and give it. If it was incorrect, they would identify it as an error, and they would repeat the entire med track once the error has been corrected. Pretty simple for you guys to be able to do. Remember, there is the red rule of medication administration. It is the never to give a medication to a patient without performing a cross-check procedure. And if any point in time that we're doing something that's unsafe or there's an error, we restart the procedure over from the beginning to make sure that it's not missed or a mistake is made. Hopefully you have any questions. We can touch base those here in a little bit, but we're going to be talking about these medication procedures just here in just a brief moment. Okay guys, the first thing I wanted to do is I wanted to talk to you briefly about the use of your MyMedic cards. One of the big things that you're going to recognize here with your MyMedic cards is going to be to make sure that we have the proper dosing. Again, we need to measure, select the right color, red from the head on the brow, rotate, measure down, see what color their feet fall in. That determines the MyMedic card that I'm going to use. In this case, I'm going to go ahead and demonstrate to you the proper technique for administering an infusion of lidocaine to a patient in cardiac arrest. In this case, we're going to use the yellow MyMedic cards, and we're going to be dealing with a patient who weighs approximately 12 to 14 kilograms. I would make sure that as I draw this up, I've got all my supplies that are necessary, which include a smaller syringe, in this case a 1 milliliter syringe. I've got my medication. I've made sure that my medication is in date. It does show that I'm dealing with lidocaine, 2% lidocaine. Here it's 100 milligrams in a total of 2 mLs, probably 5 mLs. And then I'm also going to be dealing with 20 milligrams per milliliter. Again, I can reference that very easily here on my medication box. I'm also going to have my 3-way stopcock. And this is going to be a great tool for helping me to control the dosing on these guys. I would have the proper PPE on. I also, believe it or not, do have a sharp skin here. So if I take a look at this, and I'm going to go ahead and give lidocaine, I need to give lidocaine, it's 100 milligrams in 5 mLs. That's the first thing that I'm going to reference on my card to make sure that I actually have the proper component. In this case, I do. I look at my syringe here. Again, I can see that I've got 100 milligrams and 5 milliliters, and that this leads up to 20 milliliters per kilogram, or 20 milliliters per ml, pardon me. I'm going to go ahead and reference my card here. So it says, again, I'm dealing with the patient where I'm going to be giving a proper lidocaine dose. I need to give 0.7 milliliters to this patient. Giving 0.7 milliliters out of a pre-filled syringe is very difficult to do by just squirting out some of the medication. I really have to make sure that I'm using the proper dosing. This is where I can easily draw up 0.7 milliliters in a 1 milliliter syringe. To do so, it's relatively simple. I'm going to go ahead and I'm going to take the ports off my stopcock, only 2 of them. Remove my cap. I got a little bit of air in here, guys. Get an air out of the pre-filled syringe, and then I'm going to hook that up here like so. Now what I can do is I can easily take my stopcock here and put it the right direction. You can see it. I'm going to turn this guy, the arrow wherever this is pointing to is off. So right now this guy is off. So if I try to push this, as you can see, it won't actually go. If I try to pull this down, it's going to be able to pull some air, but it's pulling air from here. Okay. Now what I'm going to do is I'm actually going to turn this off to the part that I'm not going to be utilizing, which is going to be up here. Okay. Now as I go to push fluid, you can see the syringe will go in any type of direction that I push it to. So what I'm going to do is I'm going to go ahead and I'm going to just slowly start to draw up. 0.7. Turn my stopcock back to off so I don't waste any medication, and now I can remove this. You can easily see in here, hopefully, My camera will focus. You can see that I'm definitely at now 0.7 milliliters. And just that easily, now I can go ahead and give this dose. Once I've given the dose, if I'm ready to draw more up, I can do the same thing for my additional dose. Take my stopcock, turn it up for off, and then draw myself out another 7, shut my stopcock off, and move my needle this way. Now the only thing else that I could consider doing during this process, if I'm concerned about sterilization, or maybe I set this down and it gets dirty, would be to use an alcohol prep pad to clean these sites as we go. But that's a prime example of one of the ways that you could do that. Another one that you may consider would be epi. Epi is a very common one that you can see as well too. And so you would again use your pre-filled epi syringe just like this, and then begin to draw up that medication just as you would normally. Again, make sure that you continuously move that stopcock back to the off and on position as you draw out more medications as necessary. So hopefully this is pretty helpful. It's relatively simple to do. It's a very good controlled way to do it, but you have to make sure you understand how to use the stopcock. If you have a stopcock which has extension tubing off the end of it, that's fine. You're only using really this 90-degree port here, so that's not too big of a deal. If we take a look at the I/O, the manual I/O, because sometimes we get a little confused on these, sharps out. Here again you can see that I've got my example. This is an Illinois needle. You can see that right away that the needle here is quite small. It's relatively easy for these to be bent, especially if we're using them for an adult. So you know, they're good tools, but they're not as reliable as what the Easy I/O is. But that's okay. I can take this apart a little bit to kind of show you some of the pieces. Here's your cap. That cap will come off when we're ready to infuse. Here you can see this is actually our stylet. It's just a solid metal rod that actually fills, I don't know if you can see this or not, it actually fills that little hole in there in the bevel. And that's important because when we go to put this into our patient, right, we're actually going to administer to put this into the bone, we don't want that center canal actually filling up with bone because we won't be able to infuse through it. So making sure that that cap is on and screwed on tightly becomes really, really important because it's going to help make that canal as we drive that into our site. The other thing that I can do is I can pre-measure, right? If I've got a really small kid, I don't want my needle to be exposed that's going to be more than half the distance between the thickness of their leg if we're using the tibial tuberosity. So I can adjust that down or I can make it longer if I need to. That's a really important tool, especially when it comes to stabilizing after you've placed it in. Or again, preventing you from going through the bone canal itself, past the bone marrow and into the back posterior side of the calcified bone. Again, once the needle is in, you're going to go ahead and put it in 90-degree angle, twist in a rotating motion. Try not to be swaying your arm back and forth, keeping it nice and still. And then you should feel a pop once that's in. Once that's in, I can go ahead and unscrew my cap. I can remove my stylet. That's a sharp. Sharps go directly to the sharps box. And now I can actually take my syringe and connect this directly onto here, and then either aspirate or inject fluid in here. I can also hook up a stopcock to this as well if I feel that it's necessary, just like so. So I can have another place for medications to be administered to control a bit more fluid as far as that goes. Or I can just actually hook up my line up directly to it that way. Regardless of the route you're going to take, it's definitely important that we make sure that we keep these areas clean and cap them as regularly as we can to help prevent any infection. Once this is in and my line is attached, now I need to use 2 bulky dressings. I typically like to use like some 1 and 2 inch rolled gauze. I just take it out of the package, keep it all rolled up, and stack it here on this side, stack it on that side, so I end up creating like a little bit of Lincoln logs here, and then I can tape that right down to my patient's leg, and it does a nice job of securing the actual I/O in place. Very important that we try not to move this around because it will move around, and it also sits up really tall, much taller than you would see with the actual I/O, Easy I/O, pardon me. The big I/O gun here, which you can actually go ahead and use, Does come with some instructions here, right? Nice fancy instructions. Nothing crazy as far as that goes, but it is important that we have an understanding how that works. In this case, this is for training purposes only. You got to make sure you read the directions. You don't want to put your hand here and push this down. It's going to shoot it right up through your palm. That'd be real bad. We don't want to do that. In this case, what I can do is I can actually remove the safety. Okay, take my hands, secure them in place, and then actually just press this bad boy down. Let's see if it works. I'm going to put something underneath it so it doesn't go through my desk, just in case. And then you would press it into the right location, and at that point in time you can release it. Now what you'll see here is you've got, again, your needle, but there's still a stylet inside that needle. That's that guy there that kind of sticks in there. You can see that. We'll go directly back into here. Okay. Now I can hook my lure lock, or I can hook up my stopcock again. Any of these tools would be effective as far as gaining access. Again, this is the adults. This is your 15 gauge, 18 gauge is for your peds. They're not as reliable as the easy IO or some other type of drill-like IO, but they are a good alternative to a jam shetty, because you can just see the size. Obviously, this is meant for an adult. This is meant for a ped, but the stability there, if you kind of look at the two needles, you can get a good idea that this guy here is definitely a little bit more rigid. You can also see when you hear it discharge, that ka-chunk that it makes. That's a big concern, because that could be fracturing the bone. So placement really does make a difference when it comes. Okay, so long story short, those are some of the basic things that we talked about. You've referenced your MyMedic card. You measured right at the head. You performed the cross-check procedure. We utilized our stopcock method, right, to make sure that we can give our pediatric patient the proper medication dosing. And we reviewed the use of the big gun, the Illinois or jam shetty, and we discussed some of the key things for easy IO access. Again, the most important thing is use the right tool for the right job the first time, and make sure that you perform your cross-check procedures and that you're using your reference cards for pediatrics. That's your best bet to prevent errors. You do need to know your pediatric medication dosages for common medications, epi, for atropine, for lidocaine, for fluids, defibrillations, cardioversions. Those are the things you need to commit to memory. But just because you commit them to memory doesn't mean you should wonder what they are if you don't know. Stop and look it up. That's your best bet. So I hope this has been a decent overview for you for some of the pediatric medication administration components. And again, if you have additional thoughts or comments, please let me know, or your lab instructors know, and we'll have a chance to play around with some of these things a little bit later, utilizing some chicken bones, chicken legs, and then even some eggs as we try to work on your finesse for putting in the IO. That'll be a fun activity later. We'll catch you guys in the next lesson.